And this is the first case. It's a CT scan before contrast and after contrast.
L'entre eux traverse constamment la frontière espagnole et pour cause.
Yeah.
Giant hemangioma.
Yes, and this is a giant hepatic hemangioma showing the classic peripheral nodular enhancement, and the size of the lesion is more than 6 centimeter. And you know that the giant hemangiomas contain central area of thrombosis, which do not usually fill with contrast even in the delayed films. The next. Yeah.
Hernia.
Hernia.
Rectal mass.
Yes. This is the anal canal, and this is the SQ anal fossa. Then you see a collection that is marginally enhancing and contain air fluid level, diagnostic of
Abscess.
yes, and this is very rectal abscess. Okay, this patient, sorry, this patient had the history of total hysterectomy and oophorectomy for endometrial carcinoma, followed by irradiation. And this is the barium enema exam.
Fistula.
Between
Rectum and side of vagina.
and the small bowel. And this is the fistula tract between the small bowel and the large bowel. This is post-irradiation maybe or post-operative, but there is abnormal connection between the colon and the small bowel. Yes?
Biliary radical
Yes.
dilated.
Yeah.
Due to the biliary obstruction.
What is the cause?
And what is the cause? I don't see any one or maybe cholangiocarcinoma.
This enhancing mass, the
yes, cholangiocarcinoma
of the liver, and there is some biliary radical dilatation. Then you consider
cholangiocarcinoma.
Yes, and this is cholangiocarcinoma. This is the delayed film where you see some wash out of contrast from the tumor, and you can clearly also see the dilated biliary radicals. And this is a pelvic scan of a patient with previous surgery. You can see the sutures at the site of the rectum, and the sutures are not oriented normally, but you see what looks like abnormal displacement, and this is what we call an anastomotic leak. And from this leak, and you got a lot of fluid in the pelvis, and also you got air fluid level. And this is an anastomotic leak after anterior resection for rectal carcinoma.
Barium swallowing.
Yes.
Sure, it's okay.
Barium swallowing. What is the diagnosis?
Achalasia.
Achalasia of the cardiac. Yes, there is the smooth narrowing of the distal part of the esophagus with considerable proximal dilatation, diagnostic of achalasia of the cardiac.
rectal carcinoma with lymph node.
Yes. What stage do you think?
T3.
Very good. Yes, this is T3 rectal cancer with invasion of the muscularis propria and the invasion of the perirectal fat together with mesorectal lymph node. Very good.
Pancreatitis. Acute pancreatitis.
Yes, and this is acute pancreatitis. You got swelling of the pancreas with a lot of fluid in the peripancreatic area, together with the clinical picture of fever, leukocytosis, and abdominal pain, diagnostic of acute pancreatitis.
Pancreatitis.
Rectum, also stage 1.
Yes, and this is rectal cancer. Which stage?
1. I think mucus and submucous also.
Yeah, okay. This has been proved to be at stage 3 because of this arrow points to minimal disruption of the muscularis propria. But if you say that this is stage 1 or 2, it will be considered right from the radiologic point of view. Okay.
Cavernous hemangioma.
Very good. And this is cavernous hemangioma of the rectum. And you can see these are multiple pelvic philipoli together with diffuse thickening of the rectal wall. And this is the attempt for barium enema. And you got also the extensive amount of philipoli.
This is tail gut cyst.
Very good. And this is tail gut cyst, which is one of the known cysts in the presacral area, retrorectal, and this cyst in particular usually shows diffusion restriction, as you can see here.
This hernia.
Type?
Type 3.
No.
There is bulbous.
No. Yeah, and this is type 2. Very good. This is type 2, which is known as paraesophageal hernia, where the gastroesophageal junction is below the diaphragm and part of the stomach is above the diaphragm. Type 1 is the sliding hiatus hernia. Type 3 is the stomach and the gastroesophageal junction are above. Type 4, other organs with the stomach herniating through the defect.
Ulcerative colitis.
No. Ulcerative colitis, the colon is narrow and the wall is very thick, but here you got a filling defect inside the rectum.
Familial polyposis?
Sorry?
Familial polyposis?
No.
This
very characteristic appearance of
pseudomembranous colitis.
Cauliflower.
no. You remember the vellus adenoma of the rectum, which looks like the carpet, tubulovellus adenoma. You remember it? This is very characteristic appearance, which is frond-like, big cauliflower lesion with distension of the rectum. This is a benign lesion with a very characteristic appearance. Okay. Yes, in this T1 and T2 of the pelvis, there are multiple nodular lesions surrounding the rectum. And in the T2 weighted image, you see this classic sign. You know, the classic sign of the target appearance, where you got central low signal and peripheral high signal. This is very characteristic of neurofibromatosis. And this is a case of neurofibromatosis of the pelvis.
Ulcerative colitis.
Yes, this is a straightforward case of ulcerative colitis where you got marked thickening of the rectosigmoid and enhancement of the wall with a narrowing of the lumen and the loss of the hostra. All these features are characteristic of ulcerative colitis.
Ulcerative colitis.
Stage 4 rectal carcinoma. Stage 4.
No?
No.
And this is the seminal vesicle, which is free. And this tumor has invaded the
Stage 3.
mesorectal fat, but you
And
got
lymph node.
extra mesorectal lymph node, as well
Stage
as
3.
intra-mesorectal lymph node. But the tumor has not reached the mesorectal fascia. Okay? Which part of the GI you are looking to? Yes, this is the stomach, and this is the biliary canal, and part of the duodenum. What do you think?
Answer?
Benign or malignant?
Malignant. Malignant.
Okay, this is gastric carcinoma, where you got the shoulder effect and the abrupt obstruction to the gastric emptying, and then by time you got minimal flow through the remaining lumen.
Hydated.
Yes, this is hepatic hydatid cyst with classic appearance of a big lesion with internal cystic structures as well as calcium. All these features are diagnostic of hydatid cyst.
Multiple
Gallstone.
gallbladder.
Gallstones.
Polyps or stones?
Stones.
Stones because of the acoustic shadowing, and these
Acoustic
are
shadowing.
gallbladder stones. And this patient presents by acute abdominal pain. And this is
Appendicitis.
yes, very good. This is epiploic appendicitis, and you see enhancement or thickening of the parietal peritoneum with the fat within the appendices epiploica. Very good. This patient is a young girl with upper abdominal pain and tenderness.
Gastric bezoar.
Very good. And this is trichobezoar, which is common in young girls that have some mental disturbance, and they may swallow part of their hair. Then you got a very big mass inside the stomach, which is usually mobile. This patient developed acute pelvic pain during colonography.
Perforation.
Sorry?
Perforation.
Yes, and this is rectal perforation where you got extensive air around the rectum. If you do not know the history, you may call this necrotizing fasciitis of the pelvic floor. But whenever you know that there is an intervention in this area, then you may think of perforation.
Appendicitis.
Bursitis.
Acute appendicitis with marked swelling or edematous changes of the wall of the appendix and some increase in the vascularity on Doppler study.
Look like ulcerative colitis.
Ulcerative colitis.
No.
Right.
You see the hostra, you see the distension. This cannot be an ulcerative colitis. But you see this irregularity.
Scaris.
Sorry?
One scaris, no?
I'm not hearing good.
She says scarce.
Scaris?
Yes.
No. This is the mural irregularity of the wall from one side in a female patient complaining of intermittent bleeding.
Endometrioma.
Endometriosis. This is a very classic appearance for endometriosis in the rectum. And you got irregularity, which is seen also in the MRI as mushroom shape. And this is an example. Here you see this is the endometriosis. It usually affects the anterior aspect of the rectum, while in the bladder it affects the posterior aspect of the bladder. And you got these very characteristic bright signals within the lesion, and also the classic history of periodic bleeding. Yes, this is gallbladder, which is distended. What is inside the gallbladder? Mud. Yes,
Mud sludge.
or sludge. And this is not pus, of course. And you know that pus is echogenic, but of uniform echogenicity. And this is a sludge or mud.
Liver deposit.
Of
Rectum.
yes.
Colorectal carcinoma.
And you
Yes,
see
colorectal
a
carcinoma.
mass here in the anterior wall of the rectum with multiple liver focal lesions diagnostic of metastasis. Actually, you cannot say that this is carcinoid, but you see that this is a neoplastic lesion in the rectum that is associated with metastatic deposit. But what favors the diagnosis of carcinoid should be in the clinical data, and also the well definition and significant enhancement of the lesion. But you are not supposed to say so. You say this is a neoplasm or malignant rectal lesion with liver deposits. This patient underwent mastectomy with lymph node dissection and is presenting by abdominal pain and bloating.
Rectal metastasis.
Very good. And this is metastatic deposit to the rectum. And I should emphasize this fact whenever you know that there is a primary malignancy, you should correlate with this finding until proved otherwise.
Empyema.
Of liver abscess, and this is right. This is liver abscess. You got the echogenic content of the abscess, and you may see some acoustic enhancement, and also you know that it is devoid of vascularity. Very good. And this is a small bowel lymphoma, a classic presentation, and you see a big mass with the orally administered contrast material is passing through the mass, what is known as aneurysmal dilatation, and this is considered one of the classic appearances of lymphoma of the bowel. This patient had a history of resected guest tumor, and he is doing a follow-up study which showed this appearance.
Tested metastasis.
Recurrence.
Recurrent
Was metastatic.
is local recurrence and metastatic
Metastatic
deposit.
ledge.
Very good. This patient presented by small bowel obstruction.
Look like Crohn's disease.
Yes, this is Crohn's disease, and you see the characteristic comb-like stranding of the intestinal fat.
Fistula.
Yes,
Anal fistula.
perianal fistula, grade
Interhemispheric.
intersphincteric.
Intersphincteric.
Yes, grade
1.
no. There is a side branch, then you consider it grade 2. If the fistula is only one track, and this is grade 1. If there is a side track or abscess, and this is grade 2.
Obstructed right kidney.
No.
Thrombosis in the aorta.
And this is the lesion. What do you think?
Pancreatic.
Barium leaky.
No, leucosabarium. What do you think?
Vaginal.
Yes,
Vaginal.
duodenal diverticulum. And the duodenal diverticulum here in the reconstructed image, and you see the connection to the second part of the duodenum. Then this usually the image which is supposed to come in the exam, where you see an air bucket with air fluid level inside, which is intimately related to the head of the pancreas. Then you know that this is a duodenal diverticulum. This patient is suspected by ultrasound to have adrenal adenoma.
Polysplenia.
No, and if you this is the lesion, and this is the spleen, which should be similar to the adjacent spleen, but this is the lesion. What do you think?
Adenoma.
This is not of adrenal origin. It is of gastric origin.
Guest. Behind guest.
Yes, and this is gastric guest. The typical appearance of a rounded, bulging lesion, and is usually go outside the gastric lumen.
Perianal fistula.
Intersphincteric grade.
Grade 1. Without any branch.
Very good. This patient is complaining of chronic pelvic pain, and he has a remote history of abdominal trauma in childhood. The scan showed an abnormal lesion here, which is homogeneously enhanced, and multiple other lesions in the pelvis.
Splenosis.
Very good. Excellent. And this history is suggestive. Whenever you got a history of trauma or abdominal surgery which is related to the spleen, You may think that there is some of the splenic tissue that has migrated away from the splenic bed and distributed through the abdomen, and you got the splenosis. Yes, and these are hydatid cysts in the pelvis and in the liver. You got two hydatid cysts in the liver with classic appearance, and the big one in the pelvis as well.
Anal obstruction.
Yes, and this patient had metastatic colorectal cancer with acute renal failure, presented by acute onset of abdominal pain and distension. The plain films showed intestinal obstruction, and the CT scan showed
Midgut volvulus.
very good. And this is the small bowel or mesenteric volvulus. You got whorly appearance at the root of the mesentery.
Renal fistula. U-shape.
Yeah, and this is what we call
Horse-shaped renal fistula.
horseshoe
Horse-shaped.
perianal fistula. Great. Great. If you look carefully here and you see a very small abscess. Abscess or side branch equals grade 2.
Gastric carcinoma.
Okay, this is the stomach, and the tumor is almost totally outside, and this is not usual for cancer. It is usual for
Laceration.
yes, guest tumor. Yes, and this is guest tumor, and if you look carefully and you see air and some area of cystic changes because of the guest, that is frequently bleeds, and this is due to bleeding inside the tumor.
Sliding hiatus.
No,
Reflux.
no,
Reflux.
no,
Hepatoesophagus.
Adenomyosis.
no.
You lose the structure.
Just look here. This is the esophagus, and there is no hiatus hernia. There is a mass.
In the
Yes, and this is leiomyoma, which is usually intramural with extrinsic impression on the lumen, and this is very characteristic.
Abscess.
Perianal abscess.
Renal abscess.
Yes, what this arrow points to.
Air.
Air.
Yes, and this is air inside the abscess, and the edematous changes as well as inflammation.
Hiatus hernia?
No, this lesion reaches the pharynx or the neck.
Esophageal lymphoma. Esophageal lymphoma. Esophageal lymphoma.
Yes, very good. This is a very good possibility for lymphoma because the lesion is very long. You see, starting at the neck, reaching below the screen, and it is submucosal, not obstructing the lumen and not circumferential around the lumen. And these two features are highly suggestive of lymphoma rather than carcinoma.
Pre-anal inflammatory change.
No fistula?
Yes, there is fistula.
There is fistula. Inter or trans? Transsphincteric. Grade? No. Transsphincteric 3 or 4?
3.
No.
3.
And you see this collection? The grade 1 is interhemispheric, only one line. Grade 2, intersphincteric with side branch or abscess. Grade 3, transsphincteric, one line. Grade 4, transsphincteric with side branch or abscess. Grade 5, suprasphincter. Okay. This patient is pregnant and has a 3-year history of painless vaginal mass that prolapses from the vagina.
Perhaps. Perisacral epidermoid?
No.
This is aggressive.
أيوة. Yeah.
I don't remember the name.
This is aggressive angiomyxoma.
Aggressive angiomyxoma.
Yes, very good. And this is a classic appearance. You know, the strandy and the huge size of the tumor. This is aggressive angiomyxoma. This female, young female with perianal swelling and pain, suspected to have a perianal abscess. Is this an abscess? No. It's a tumor. Yes. What do you think of such a tumor in this location, in this age? It's not related to this. Sorry? Yes. And this is rhabdomyosarcoma, which is well known in this young age, and this is also one of the well-known locations.
Gallbladder carcinoma.
Very good. And this is gallbladder cancer, a mass at the fundus of the gallbladder.
Acidosis? No.
Cholelococele type?
Type 3.
Type 2, which is a colloidal diverticulum. Yes, and then the type 3 is the cholelococele. And here you can see the lesion. This lesion is filled with fluid, not air. And if you see such a lesion, you may think of this diagnosis as colloidal cyst. Perianal fistula
Perianal abscess.
and abscess type?
Type 4. Type
4. Yes, type 4. Grade 4. Transsphincteric, and it goes through the sphincters with the formation of a big abscess in the perineum. This is type 4. This patient had severe abdominal pain after percutaneous nephrostomy.
perforated gallbladder.
Very good. And this is gallbladder perforation with biliary peritonitis. Very good. Yes, and this is iron overload because of multiple blood transfusions.
This is perisacral dermoid cyst.
No, this is the diffusion. The most famous one is
Duplication cyst.
no. Duplication cysts do not cause diffusion restriction. Okay, and this is still gut cyst. Once more, okay. And this is the splenic tumor. And I said before that whenever you are asked about the differential diagnosis, you mention the primary lesion in this area, then you mention lymphoma and metastasis. Then what is the primary lesion here?
Angiosarcoma?
Yes, and this is angiosarcoma. Then you start first by the primary lesion, although it may be rare. But you say that this is angiosarcoma. Then what are the differential diagnoses? Then you mentioned lymphoma and metastasis. Okay.
FNH.
Sorry?
FNH.
No, this is the arterial phase. It is not enhancing. Hydatid?
cyst.
It does not look like the hydatid.
Hemangioma.
No, it is not filling in the dilated phase.
Hepatic adenoma.
It is not significantly enhancing in the arterial phase.
Lamellar. Hepatolamellar.
Yeah, no, but this has been proved to be an abscess, although it's an odd appearance for an abscess, but it has been proved to be so by biopsy, of course. Then, what do you think?
Regeneration nodules.
Gastric carcinoma.
Gastric carcinoma. Regeneration nodules, the liver is not cirrhotic. Then gastric cancer, where is this one?
Diffusion signal.
This is you do not judge the wall of the stomach if it is not fully distended, and this stomach is not fully distended.
Multiple hepatic cystic lesion.
Yes, these are benign cysts. Is there any
Benign.
other lesion?
I see some small hypoechoic the liver look like deposit.
No, these are cysts we agree about.
Yes.
Cystic metastasis.
You see this?
Yes.
What is this? No, the same angioma. You see the peripheral nodular enhancement in the CT and the peripheral nodular enhancement in MRI. In this film, you may feel that this is an extrahepatic lesion, but here you see the classic appearance of the enhancement of the hemangioma, which is known as exophytic hepatic hemangioma. This patient presented by abdominal pain after low anterior resection of cancer colon 6 months ago.
peritoneal ceiling, chocolate cyst.
No, no. And this lesion is away from the operative. Sorry?
Foreign body reaction.
Very good. And this is known as gauzy lymphoma or retained surgical towel or surgical gauze. And actually, it should contain some air loculi in order to identify. But this is also one of the classic appearances that sometimes it may be mistaken for hydatid cyst, for example, but it is not the case in MRI.
Multiple abdominal cyst.
Multiple
Abdominal cyst.
multiple abdominal cysts or intestinal obstruction.
Peritoneal obstruction.
Intestinal obstruction.
Now, if these are
Abscess.
the small bowel, look to the rest of the small bowel. These are cysts in the
This
abdomen.
is hydatid cyst.
Yes,
Hydatid cyst.
these are what is known as
Hydatid cyst.
peritoneal
Hydatid.
hydatidosis or multiple peritoneal hydatid cysts.
Cyst.
Abscess.
Yes.
Abscess. Peritoneal abscess.
Peritoneal
Peritoneal abscess because of the history, diabetes and chronic renal failure, peritoneal dialysis, fever. You got marginal enhancement, internal air loculi, all are pointing to the diagnosis of an abscess.
Fatty liver.
Storage.
Liver, yes, and this is the T1. You see the brightness of the liver, and this is T1 out of phase, and you know it by the dark line outlining the organs, and you got the suppression of the fat in the out of phase image, diagnostic of microscopic fat.
Carcinoma tumor.
Yeah,
That's it.
the patient
HCC.
had carcinoma tumor.
liver wandering اللي هو wandering liver not in this.
Wandering liver, there is no diagnosis like this. The spleen is only wandering.
Metastasis.
Yes, and then I will
Yes,
emphasize once more, I swear that if you know that the patient had a primary malignancy, you should consider. And you say that these are metastatic deposits until proved otherwise. If you are asked about the differential diagnosis, forget about this and say this is multifocal hepatocellular carcinoma or lymphoma or metastasis.
Pancreatic cyst.
Okay. There is no simple pancreatic cyst. And this
Yes.
cyst showed diffusion restriction.
Abscess.
Mucins.
Yes.
Intrahepatic bilirubin.
Tumor. You should know that the pancreas do not have a simple cyst. And whenever you see cystic tumors in the pancreas, we diagnose pseudopancreatic cyst or pancreatitis, pancreatic abscess, or cystic tumors.
Dear Dr. Messina, cystic pancreatic cyst can be small size.
Yes, it may be so. It is well known that the mucinous tumor is large and contain multiple septations and also different signal intensities within the loculi. But if you see such an appearance, you should consider a neoplasm.
What about liver, doctor?
Liver?
Intrahepatic bilirubin.
No, here?
What is good
Yes.
blood?
This is the gallbladder fossa and some of the duodenal loop, but the liver is good.
Okay.
HCC.
HCC, yes, this is arterial phase with enhancement, washout, and the delay enhancing capsule, typical of hepatocellular carcinoma.
Diverticulitis.
Yes, and this is chronic diverticulitis with thickening of the sigmoid, stranding of the pericolic fat, and what is very important, the presence of multiple mural divertically containing air.
Lamella.
No,
Cholangiocarcinoma.
no.
focal
Hemangioma. This is a simple giant hemangioma, low signal in the T1, high signal in the T2, nodular marginal enhancement in the arterial phase with closing iris sign in the portal and the delayed phase. And you got no deformity of the hepatic capsule, diagnostic of a hemangioma. This patient had progressive abdominal distension.
Peritoneal cake.
Pseudomyxoma peritoneal.
No, this is impossible. You cannot diagnose pseudomyxoma unless in the
Gelatinous.
liver or the
This,
spleen. But here you got an omental cake or a mental deposit with massive ascites. Then, if you see an omental lesion and you do not know the cause, and these are the differential diagnosis, please remember this very well. Peritoneal deposits, peritoneal lymphoma, and the primary tumor of the peritoneum, which is malignant mesothelioma. Of course, TB may be considered here, but there are some features that may suspect this diagnosis. Then, if you do not know the diagnosis, and the policy is to go straight forward by a needle biopsy to have a sample of this lesion to know, to confirm first the diagnosis and to look for the primary lesion if it is metastatic. Yes, and this is intersphincteric abscess or horseshoe abscess. Gallbladder polyps. Yes, because of the absence of the acoustic shadowing.
Head of the pancreas, there is tumor of the head.
Yes, and this is pancreatic head cancer, a
Yes.
mass in the pancreatic head with severe dilatation of the common bile duct,
Yes.
as well as intrahepatic biliary radical dilatation.
Calcification, hydrated.
That's
Yes, hydatid cyst. The patient had motor vehicle accident with comminuted tibial fracture, and the abdominal and pelvic CT included in the trauma workup. No evidence of laceration, but there are multiple focal lesions showing marginal calcification, typical of hydatid cysts.
Paniculitis.
Yes, and this is mesenteric paniculitis, where you got infiltration of the mesentery with the vessel halo sign of fat around the mesenteric vessels.
appendicitis.
Acute appendicitis with appendicolis. The appendix is distended by fluid with stranding of the periappendicular fat, and there is decalcified appendicolis inside.
stone
Graves
enters.
syndrome.
Sorry?
There is a stone in the cystic duct.
Yes, there is a
Mucous
stone in the cystic
gallbladder.
duct with distension of the
Of
gallbladder,
the gallbladder.
known
Gallbladder.
as gallbladder mucocele or hydrops of the gallbladder.
What is abdominal carcinoma?
Of?
Gallbladder.
Yes.
Antrum.
Yes,
Breast
this is
carcinoma.
gallbladder cancer, and you see a mass in the gallbladder fossa. In spite of this is without contrast, but you can clearly identify the lesion.
Rectal polyp.
No?
CA rectum.
Yes. Stage?
It's stage 3.
3. Very good. This is rectal cancer, stage 3, infiltrating the mesorectal fat
It's rectal fascia.
along the
Yes.
anterior and the posterior aspect in the presacral area.
Umbilicated appendicitis.
By?
Reception.
Yes, and this is perforated appendix with the formation of periappendicular multilocular abscess containing air loculi as well as a stranding of the fat with the appendicalis inside. And this is one of the pathognomonic landmarks of this lesion to belong to the appendix. And this appendicalis should be surgically removed whenever draining this abscess, unless it will remain and form a foreign body that will accumulate once more infection.
Focal lesion in the head of pancreas.
No, this is the head of the pancreas, which is good.
Acute cholecystitis.
Acute
Non-calculated.
cholecystitis. What do you think of this fluid?
Perforated gallbladder.
Sorry? What is the diagnosis? That's granulosis? No. The wall is not thick and they don't contain cystic changes. But whenever you see this, if the fluid is circumferential around the gallbladder, this is very cholestistic edema. But if you see that the fluid is localized to a certain part and this is perforation, then you should consider that this gallbladder has perforated with leak in the very cholestistic area, and there is a possibility of developing biliary peritonitis. very good. أنا الحقيقة انتوا أشطر مجموعة أنا قابلتها لحد دلوقتي، ويعني إن شاء الله تستمروا على كده بإذن الله، ودايما موفقين، وربنا يوفقكم دايما إن شاء الله. شكرا
بارك الله فيك.